Okay, so I kind of talked about the treatment of increased intracranial pressure. This posturing is really important for you to know. Okay, so managing, I'm not really going to go into these drains. The only drain I want to talk about that you may, I wonder if I have it here. I don't, but I have it on another slide. You're going to have to know about a VP drain, and I'll talk about that in a little bit. But if anybody has a drain, or like an open skull fracture, or they had surgery, you're always, or like they're a college kid living in a dorm with a bunch of people, right? Meningitis is meningitis no matter how it's contracted. And there's different types, viral versus bacterial, but they're going to have the same signs and symptoms, is my point. So these two meningeal signs, Brudzinski's and Kernig's, okay, you're going to have to know. You definitely have to know that. That's highly tested, and I don't know if one of them was on practice A. So Brudzinski's is when you flex the neck and they bring their legs up, so their lower extremities flex. Okay. Then with Kernig is they can't straighten their knee. That's how I remember that. So with the hips flexed and the leg flexed, they cannot extend their knee. So that's how I remember those two. So they're going to have the classic triad for meningeal signs is fever, nuchal rigidity, and mental status changes. So to remember the signs and symptoms, you can remember this mnemonic. Shh, it happens. Okay, so seizures, they're going to have seizures, high temperature, impaired confusion, increased intracranial pressure, and irritability. They'll be tired, have a headache, which is obviously altered mental status or aphasia, photophobia, projectile vomiting, especially in kids, petechiae if it's bacterial, which is, petechiae, like a petechial rash, like across their chest or something. Emesis, so that's projectile vomiting. The nuchal rigidity and nystagmus. So remember, the nystagmus is the involuntary movement. Did I tape again? Am I taping? Because I'm giving you a lot of good information here. Yes, I am. Okay.
Yes. Yes.
Okay. Tachycardio. And this word episthothonus, this is just, you don't have to know that. That's like another type of posturing. You can Google it. It's pretty interesting. Um, okay. Make sure you want to wash your hands. Obviously, if you suspect somebody has this, you get them in a room by themselves and institute droplet precautions. One of your main priorities, if somebody has bacterial meningitis, is to get that antibiotic into them. Okay, because it's the only thing that's going to fix the meningitis. If you fix the meningitis, you probably fix increased intracranial pressure. Okay. So lumbar puncture is going to be done if they don't have increased intracranial pressure, and that's to culture the CSF. Okay, really important for you to know that because that was a proctor question. And so to prevent increased intracranial pressure, the head of the bed has to be 30. Now, they have a pillow under this head, but that looks okay because see how the head and neck are in proper alignment so that the cerebral spinal fluid can flow down easily. Okay, so that's why we keep the head of bed 30. No hip or neck flexion, no clustering of activities, which is like breaks my spirit as a nurse because I love getting everything done in one shot, but you can't do that. You have to space out your activities because too much activity is going to increase their intracranial pressure. Get them in a private room, make sure it's quiet, make sure the lights are dimmed because they have photophobia, and put them on seizure precautions. Make sure they have O2 flowing or it's available, and make sure you have, if you have to suction them, that you hyperoxygenate. Make sure they're on a stool softener. No coughing. Make sure you take care of any fevers because that's going to increase intracranial pressure. All right. Now, we're going to talk a little bit about, delegation to the UAP. You're going to have to tell them not to cluster care. You're going to have to schedule this positioning. Like you can reposition at this time, and this time, right? They should never slide the patient up in bed with their arms underneath somebody's shoulder. Do you know that position? Always use a pull sheet. All right, so if somebody has hemianopsia, which means they can't see out of one side of their eye, you want to approach them from the unaffected side, and you want to put everything on the unaffected side, and we'll go into more detail with that. Feeding. When you're feeding a patient with dysphagia, now dysphagia means they can't swallow or they can't swallow well. They have a problem swallowing, okay? You always feed on the unaffected side, 1 teaspoon at a time. They cannot drink and eat at the same time. They need to put their chin to their chest to swallow. No, absolutely no straws. Head of bed has to be up, and it needs to be up for 45 to 60 minutes after they eat. So don't put them supine. The other thing is, don't allow them to be distracted. Like, you shouldn't be feeding somebody with a bunch of their family members in the room talking to them, or like if the patient's like watching their ball game or watching a TV show and they're really like into it. That's not the time to feed. They have to concentrate on what they're doing. Okay, that's really important. All right, meningitis, 3 different types. Um, Here is the VP shunt. Now, who would get a VP shunt? People at risk for hydrocephalus, like if they had recent brain surgery, that could be a reason. Some people are just born with it. But anyways, this could be a reason somebody gets meningitis too. What this shunt does, it's put in the ventricle of the brain, and it's put in their peritoneal cavity, and it drains the cerebral spinal fluid from the ventricles of the brain into the peritoneal cavity. So that's that. Somebody with an ear drain. I have an ear drain right now because I've been having trouble hearing, and that's to drain the fluid from my ear. And that could make me more at risk for meningitis because my ear is right next to my brain. So that's something to look at. We went through these findings that you normally see in increase intracranial pressure. These meningeal signs are going to be very important for you to know. Okay, now we talked about the lumbar puncture. Now, in general, patients are going to have a high white count, and you're going to get a bunch of cultures to try to figure out what causes the meningitis. But when you do the lumbar puncture for cerebral spinal fluid, you'll see white, and this was a proctor topic. You're going to see high white blood cells, protein, and decreased glucose for bacterial meningitis. And how I remember that is bacteria love sugar, so they're going to eat all the sugar in the cerebral spinal fluid, and that has low sugar. It's going to be cloudy if it's bacterial, and it'll be clear if it's viral. So that's an important distinction. I already went over the treatment, Mocha Mom. And let me see, seizure precautions. I told you about the private room. And then to prevent increase intracranial pressure, I already talked about keeping it quiet, reducing fever, avoiding hip and neck flexion, no coughing, and sneezing, head of bed with neck and head in neutral or a proper alignment position. That's important. All right, spinal cord injury. There's like a lot of reasons people could have spinal cord injury. Sometimes it's doing stupid stuff, but sometimes it's like, car accidents they have no control over. Diving. Before you dive into any body of water, you have to figure out how deep that water. I mean, I just wouldn't dive into water. High risk groups. We talked about males before. And my apologies to the males in the group, but seriously, you got to stop taking all those risks. We talked about older adults before. There's all kinds of injuries that could happen. It depends on what kind of injury you have. You could have a complete, you could have incomplete. It could be, C8 and above, which means you're quadriplegic, or T12 and below, which means you have paraplegia. So you So the new name that you need to know for quadriplegia is called tetraplegia. That's what we're calling, here it is, right here. That's what we're calling it nowadays, tetraplegia. All right. So anybody with C4 and above, if they had damage to C1 to C3, they probably didn't survive the whatever was causing it, because that is where your breathing nerves are in that area. Just say that. Okay. Anybody with cervical is going to need assistance with bleeding. T6 and above, I talked about. The autonomic dysreflexia, spinal shock, and neurogenic shock. I think you did a case study going over it. But basically, anybody that has a spinal cord injury is going to have temporary loss of motor, sensory, and function reflexes below the level of the injury. Now, this is important. What happens is that this could resolve in a couple of days, it could resolve in 6 weeks. But what happens is when their reflexes return, okay, so the patient's going to look like they're moving their legs, and the family gets very happy. However, you have to tell them it just means that the reflexes have returned because they start to think, oh, they'll be able to move again, which is not true. So it's kind of sad. Um, so we talked about, you don't need to know, let me see. We talked about T6 and above. Um, the most important thing that you have to remember is autonomic dysreflexia. Right. T6 and above. So remember that. Flush place in neck, parlor below the level of the injury, severe headache, diaphoresis, bradycardia, erection. This is like goosebumps. They get that too, nasal conditions. And we talked about all the triggers, so make sure you review those and what to do. Like get the head of the bed up, find the cause. Really important. We talked about the halo device, and how it can lead to safety issues, doing pin care. And here is the cervical thongs. This is somebody asked me about how do you move somebody. So this is skeletal traction. We don't really use it that much. In fact, I haven't seen this in a long time. But anyways, if somebody has this, what you have to remember with the nursing care, of course, you're going to like make sure these weights don't touch the floor and you're not going to touch the weights. But if you have to move them, you need help because you have to move them in a log rolling fashion. Okay, now prevention, that is very important. Everybody should be wearing helmets if they're on wheels, okay? Skateboards, razors, roller skates. If you're on a wheel, you need a helmet. Everybody should wear seat belts. They shouldn't dive in shallow water. Don't drink and drive. Don't drink and do drugs and drive. Lock up your guns and don't ride in the back of a pickup truck. Just things like that to prevent spinal cord injuries and head injuries. Okay, you guys tired? Does anybody have any questions?
I'm exhausted.
Yes, Angie, sorry. Are you asking a question, Angie? Because your mic's on, I think. I can't hear you.
I have a question.
I'm sorry.
Okay,
I thought I was
Oh,
on mute
okay,
on one side. Can you hear me now?
I can.
Okay. I put a question in the chat in regards to meningitis. I
Yes,
read that it was reportable to the CDC.
it
Um,
is.
okay, all three types?
Yes.
Okay, and the reporting, is it based off the protocol of the facility or is it just that we have access to the CDC directly?
Your manager would take care of that.
Okay.
You have like, where do you work now? Do you work in a hospital?
I don't.
Okay, so like usually there's a quality, a QI nurse, or it could be, um, God, what do we call that? Infectious disease physician. There's usually like a head, so they would take care of that. You just probably need to know. Was that on practice day?
I know I saw it somewhere about reporting it to CDC.
I have it in here that you have to report it to CDC.
Okay.
So maybe you
Perfect.
saw it there. I don't
I
know.
probably did. And then I have another question.
Okay.
During class, our instructor mentioned an injury to cervical 1 through I believe 3 and what that would look like. I think I saw an image in one of your slides here for the flexion, and you said most likely the person would not survive based on the nerve damage there.
Yeah, because okay, in C1 through 5 keep me alive. So C1, 2, and 3, the phrenic nerve, which innervates the diaphragm, is located there. So if somebody has an injury in that area, they usually die on impact.
Okay.
Yeah. If they have C4, like the injuries at C4, they might be okay, but they're going to need some kind of assistance with respirations. And
Okay.
then, of course, anything below that, like if it's C5, C, they might have a trach with ventilation for the rest of their lives.
Okay, perfect. And I have one last question. I'm sorry.
That's okay, you're fine.
Um, So if for a lot of the intracranial pressures or any kind of injuries to the brain, if somebody is elderly, lives alone, gets sick, it would possibly be that it would be a very long, maybe death if they're alone and nobody really checks on them. Is that true?
That could be true with any older adult. It could be true with anybody, I guess, that doesn't have anybody checking on them. But what are you saying? Like if they fall, is that
Right. Right. Like if they were, if they live alone, they fall, and then they just I mean, I don't know. I'm assuming here that they don't have anyone checking on them. They don't even, maybe the neighbor notices they haven't been outside watering their plants or
yeah, that
whatever.
could be a real problem. I've had, like working in the hospital, I've had like people come in that were on the floor for like 3 days. They couldn't move. That does happen, and they can't get to a phone.
Okay.
Yeah, it does happen.
Okay. Thank you.
You're welcome. Somebody else had a question.
I just wanted to know where the recording was going to be posted. That's all.
In your classroom, I have there's like it says, I think, recorded tutoring or tutoring.
Oh, okay. All right.
Yeah, so I'll put everything in there, and I have last semester's in there too, so you can kind of look at that too. And then next week we can go over like stroke and see, the rest of the stuff that you're going to need to know.
Oh my God. I thought we was done. Okay.
The what? You thought
I
that
said
was
I
it?
thought we were done.
No, I mean I could keep going, but I'm sensing that y'all are tired.
Yeah, I am. I had clinicals today, so yeah.
Oh, you did?
Yeah.
Where are you?
I did maternity at Johnson Willis
Was
on
it
the new
good?
corner. Yeah, it was fun. I learned a lot today.
Okay, good.
Yeah.
Sometimes, like, those the specialty nurses can be snooty.
Oh
That's good.
no, 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 no.
I'm
They were
glad.
fine. We did good.
Okay, awesome. That sounds great. All right, do you guys have any other questions for me? All right, I am going to put